Good evening, Dr. Phil here. Today we'll be discussing on post-operative strategies to prevent post-operative pulmonary complications. General anesthesia and post-operative analgesia can contribute to PPCs by adversely affecting mucociliary clearance, FRC, VQ matching, surfactant production, immunity, cough reflex, and muscle power. Emergence from anesthesia. Employ measures whenever possible that avoids lung de-recruitment, such as optimizing patient positioning, elevate the head more than 30 degrees, avoiding zero PEEP, avoiding suctioning of the tracheal tube just before extubation, prevent coughing or bucking on the tracheal tube, avoid upper airway obstruction after extubation, and avoid turning off the ventilator to allow CO2 accumulation to stimulate spontaneous ventilation, as the period of apnea is associated with zero PEEP and atelectasis. FiO2. Avoid FiO2 of more than 0.8 during emergence when clinically appropriate, which increases atelectasis. FiO2 of 0.4 and below should be used during emergence when clinically appropriate to reduce absorption atelectasis. CPAP with low FiO2 of less than 0.3 post-extubation may decrease the area of atelectasis. However, this technique cannot be presently universally recommended, as current evidence regarding its efficacy is lacking. Post-extubation, supplemental oxygen should be administered for SpO2 less than 94% under room air. The underlying cause for desaturation should be investigated, such as opioids, hypothermia, diffusion hypoxia, inadequate reversal of muscle relaxants, residual effects of anesthetic agents, airway obstruction, atelectasis, pneumonia, etc. Appropriate interventions should be administered. Pre-op measurement of PaO2, SaO2, and PaCO2 assists in establishing a realistic target for each patient. Patients with advanced COPD or chronic hypercapnia may be dependent on hypoxemia as their main ventilatory drive due to downregulation of central chemoreceptors. Oxygen concentration should be controlled, for example by using Venturi masks, and titrated to optimize oxygenation and prevent hypoventilation. Adequate monitoring should be available, such as serial ABG measurement. Pulse oximetry only shows SpO2. Humidified oxygen aids physiotherapy and sputum clearance. Ensure regular monitoring and reviews, assess vital signs, pay particular attention to respiratory rate and SpO2. However, respiratory deterioration may have non-specific signs, such as confusion, tachycardia, fever, and malaise. Urgent investigation and aggressive therapy should be employed when respiratory deterioration is detected. Consult intensive care or outreach team early if the patient does not respond to initial treatment. Multidisciplinary protocols applied before and after surgery have been designed to reduce PPCs, which are based on ensuring adequate reversal of neuromuscular blockade. Residual neuromuscular blockade is associated with post-operative hypoventilation and increased PPCs. Adopt semi-recumbent or upright positions. Aim for upright posture post-op instead of supine when feasible to improve respiratory performance, FRC, and clearance of secretions. Early mobilization reduces the incidence of thromboembolic disease. Early chest physiotherapy includes coughing, deep breathing exercises, and incentive spirometry, aids clearance of secretions and reduces atelectasis. Ensure optimal pain control. This is essential for maintenance of efficient respiratory function, compliance with physiotherapy, early mobilization, and to minimize cardiac stress. Employ opioid-sparing analgesia whenever possible, as opioid-induced respiratory depression can contribute to increased PPCs. Examples of opioid-sparing analgesia includes paracetamol, NSAIDs, magnesium sulfate, and ketamine. Local or regional anesthesia should be employed when indicated. However, weigh the benefits of opioid-based analgesia against the benefits of regional anesthesia. Consider early consultation of the pain management team when necessary. Next strategy is careful management of fluid balance. Adequate intravascular filling is important to maintain adequate perfusion of organs. However, certain patients tolerate fluid overload poorly. For example, patients with lung disease are at increased risk of pulmonary edema. A dilated right ventricle due to pulmonary hypertension may mechanically compromise the function of the left ventricle. Patients with heart failure and oliguric renal failure tolerate fluid overload poorly. Document intake and output charts clearly. Consider short-term stay in intermediate critical care units if clinically appropriate. Non-invasive respiratory support. There is weak evidence that post-op CPAP after abdominal surgery may reduce atelectasis, improve oxygenation, reduce pneumonia, reduce reintubation rates, reduce duration of ICU or hospital stay, and reduce PPCs by helping to avoid reintubation in patients in whom respiratory failure has an underlying transient and modifiable cause. NIV rapidly relieves dyspnea and reduces the work of breathing and re-expand collapsed areas of the lung. BiPAP should be preferred over CPAP when hypercapnia is predominant or coexists with hypoxemia. Candidates for NIV should be selected with caution, and NIV is not deemed to unjustifiably delay an unavoidable intubation. Prophylactic post-op NIV or CPAP should be considered after extubation of patients with prior routine use of NIV or CPAP. There is still a lack of strong evidence to recommend the routine use of NIV to reduce PPCs, and further RCTs are warranted. The optimum CPAP is unknown, and the administration of CPAP should be individualized. Regarding high-flow nasal oxygen, this mode of NIV lacks efficacy in the post-op settings in reducing PPCs, as it only provides minimal positive pressure effect, which is inadequate to reverse atelectasis. These are my references. Thank you.